dear friends. I'm really thankful to Physician Forum of India, Dr. Chauhan and his team, to give me a chance to moderate yet another session. And in the power play of 2023, it's the second over only. And my pleasant and biased duty to introduce to you none other than Dr. Vanita Arora, to whom we have at least, I think, 6-7 CMAs we have had from her, and we know her from her days from when she was working with Max Super Specialty. Now she has moved to, I think, a better place as per her CV. She is now Senior Consultant, Cardiac Electrophysiologist and Interventional Cardiologist at Indraprastha Apollo Hospital. I have great regards. I have sent a few patients and I am super satisfied. Her areas of interest are AICD implantation, cardiac resynchronization therapy, pacemaker implantation, physiological pacing, say it's bundle or lateral pacemaker implantation, physiological pacing. Leadless pacemaker is the new device. We will have, I think, more time on leadless pacemaker when she is finished with her talk. Arrhythmias and RFA, which is very commonly used now. I will not give more time to her introduction. I will rather give her more time to interact. I will request her to keep her talk crisp and short so that we spare more time. We have many questions to clarify our doubts about pacing. All to you, ma'am.
Thank you so much for the kind words, Dr. Kalra. And before I start my talk, it is always a pleasure to be in Physician Forum. South Delhi Physician Forum is one of the, not even one of the, it is the best forum I have ever interacted with. Yeah, whenever a speaker comes to talk to you, it is, they are prepared, they really have a lot of questions. And when those questions come from the forum, it is a pleasure to interact. Because then you know that your voice has been heard. And whatever said and done, I may be saying 10 points, you may take back home 12 points out of that. But once your message is conveyed, you are happy. And in this forum, my message is always conveyed and I have such a wonderful interaction. I mean, Dr. Kalra, Dr. Tuli, I have had fun with them, interacting with them, because I become a student again. The way they ask questions, you become a DM student again. And it is really fun. Sachi Dr. Vanita.
So you said Dr. Tuli.
Oh, Tulsi, sorry sir. देखिए, आपका डर देखिए. मैं यहाँ खड़ी हूँ, मैं डर रही हूँ देखो. Dr. Tuli तो interact करते हैं. Dr. Tulsi question.
बात interfering आ रहे हैं.
Sir, मेरा ना ये देखो, टांगे कांप रही है आप. So now coming to the session which has been placed today, I will be talking on two modalities of pacing. Pacing is my passion, and there have been recent advancements. They are two very different therapies, absolutely 180-degree different from each other, but they both are the advancements in the present day era, how we are doing pacing. So first of all, I will talk to you about this therapy. This is known as a leadless pacemaker. So this is how the pacemaker has become now, a vitamin pill, capsule shape with no leads. That's why it is called as leadless pacemaker. Our conventional therapy used to be a subclavian access that we used to take. Below the collarbone we used to put this device and the leads would go in the heart. But over the time, what we have seen is one of these complications occurring with the patient. Either there is a pocket site infection, there is a hematoma, the leads get fractured, or over the time wear and tear occurs and the insulation break occurs and patients present back to us after a couple of years with these kind of complications, and it is a havoc to manage these complications. It really is a havoc for the patient and for the physician who's managing these complications also. So we had been thinking, what can we do better to help these patients? You know, how do we do that? The pacing innovation occurred in form of miniaturizing the pacemaker. This was the first human implant pacemaker which was done in 1959, and this is the first leadless pacemaker implant which was done. Look at the size of the pacemaker in the hand of the patient. This has been the miniaturization, and the technique has totally changed. The entire battery and the leads have been, compressed into the small capsule, which is, this is what is it, the leadless pacemaker. The volume of this pacemaker is 0.8 cc. It's just 2 grams in weight. These tines which you see, these are the leads which are in this pacemaker. These are the nitinol tines, 4 of the nitinol tines which have replaced the leads. This is the anode, this is the cathode, and this is the anode from which the pacing thing occurs. The trajectory, the battery, everything has been compressed into this capsule. It's just the size of a vitamin pill, which you prescribe. Bicasol jo dete hain hum, bade shock se patient ko, that capsule, which is just the size of that. And this is the area from where it is attached while we mount it on a catheter. The catheter that we use to implant, this is the catheter. The French size of the sheath is 24 French, the outer diameter is 27 French. This is how this pacemaker looks like mounted on this catheter, and these are the tools that we use to actually deploy leadless pacemaker in the heart. So this is how we go through the groin. We go through the femoral root. We take this pacemaker, we cross by the deflectable sheath, we cross this into the right ventricle, and then we give it a clockwise twist going towards the septum, and we implant. Once we find a good place, we take a check shot to see the trabeculae in the right ventricle. Once we see this trabeculae, which are the muscles of the right ventricle, then what we do is we actually increase the gooseneck on this pacemaker. This is the gooseneck has been increased so that it is just abutting on the septum. Once we are able to do this, we release the leadless pacemaker. This is coming out of the sheath. It is implanted, and we go slow for the first half of the implantation, and then rest implant we go, and this is how it is detached from the catheter. Now it is still not free. You see, it is still not free because there is a thread. We can't see this thread. The thread is in my hand while I am implanting this. So it is still attached to the leadless pacemaker, because we have to do the tuck test. First of all, we do the tuck test. This is how we do the tuck test. We pull from those threads and we see the movement of these nitinol tines, that they are secure. If you can see the movement of 2 of the tines, that means you will require 15 times the force to pull it out. That means it is very well implanted. So without doing this tuck test, we cannot release the tethers. But before that, we do the electricals. We place the magnet on the chest of the patient. We see that all the parameters are good. We are happy with it, and then we deploy this pacemaker. We cut the tethers and we release the pacemaker there, and it is in the right ventricle. Now, once we are implanting, this cartoon shows that once we are implanting the leadless pacemaker, in case we are not happy with the parameters, as long as the threads are in my hand, I can actually take it back, put it back in the sheath, and go to a different site and implant it. So we are safe. We have to secure the pacemaker. That is the most important thing. People ask me, what are the indications of implantation of pacemaker? Well, initially it was a single chamber pacemaker. It was a VVIR pacemaker. That's why we used to look at 6 sinus syndrome with bradycardia. We used to look at patients, we were not looking at AV conduction disease patients. We were looking at patients who had anatomical problems. That means they had had previous surgery or somehow have a subclavian stenosis. Then we can go through the femoral route. In case patient is already infected with the pacemaker, you used both the sides, the patient is infected, then you have to take out the device and implant. This is the safest pacemaker. There is no case report till date of the 70,000 pacemakers which have been, more than 70,000 pacemakers which have been implanted worldwide. there is not even a single case of infection with this pacemaker because it is a totally closed circuit. Nothing is in the skin, there are no hematomas, no infection. So, but now these are the studies which have been done post release, market release studies, and we have seen that re-interventions, chronic complications, they were all less with leadless pacemaker. I had the opportunity of doing the first live case of leadless pacemaker in 2016 at TCT India live, and God's blessings were with me, and this case was successful. Now I will give you the examples of 1 or 2 patients before going on to what has happened latest in even leadless pacemakers. So this is one patient, these are the indications. In India we are finding these indications because it is still very expensive therapy, so we have to select our patients. We can't give it to all the patients. This is a 60-year-old male who had his first transvenous pectoral right-sided implant in 2014 for complete heart block at a government hospital. It got infected, he went to another hospital, they did the pocket revision. What they did, they opened the pocket, cleaned it and stitched it again. Now then it got infected again. They went to a private hospital, again they did a re-implanted in the subpectoral. They went below the skin, below the muscle, and in that region they implanted the pacemaker. Anyway, after 3 years he had a RV lead dysfunction. So he went, a RV lead was changed, the right ventricular lead was changed. Once this lead was changed, it again got infected. So he came to us with this, the extrusion of the pacemaker. All the 3 leads were there. We took time, took out all the 3 leads, and the only answer he had was to have a leadless pacemaker, and we successfully implanted it. So these are the case studies, I am just giving you the case studies where we have selected very meticulously, we have selected the patient for doing leadless pacemaker. Another patient, a 39-year-old male, young guy, he's had AVR and Bentol surgery. 3 past cardiac surgeries he's already had. Now he develops complete heart block. His axis, subclavian axis, axillary axis is all blocked because of the previous surgeries. They do cannulate the coronary sinus, so they go with the venous lines, So all axis is blocked. What do? We came in for the rescue for this patient to do a leadless pacemaker, and this patient is doing fine, 39 years old. Now you will ask, why did he undergo a surgical implant? Why did we give him a epicardial, why give him a leadless pacemaker? Why not an epicardial implant? The surgeons refused to operate on him. He had 3 surgeries. His pericardium, whatever was left, his heart was actually attached to the sternum. So they could not open it, they refused to open it. Hence we went ahead with the leadless pacemaker. So these are the indications, where we have done. Now what has been the new advancement in this is that we have AV micra. That means we have a dual chamber micra which senses the atria and paces the ventricle. It's like having a dual chamber leadless pacemaker. What we have done here is, it's a very interesting algorithm that we selected. On this EGM that we had from the accelerometer EGM that we had on the micra, we selected the A4 wave, which is the actual mechanical contraction of the atria, and that was very consistent with the mechanical A wave. That means the P wave is formed first, then the mechanical systole of the atria starts. So it was corresponding with that, and we introduced this algorithm into the AV micra to make it a dual chamber micra. So it senses the atria and paces the ventricle. Rest all the parameters remain the same. The pacing, battery life of these leadless pacemakers, 100% pacing is more than 10 years. It is MRI compatible, 1.5 and 3 Tesla both, and they do very well. The study has shown very promising results. Now we have further gone ahead. I told you the axis that we use is the femoral axis. Now if the patient has the axis problem in the upper limb, then you use the femoral axis, right? But if the patient has a problem in the femoral, what do? I have done this first micra of Asia Pacific. We have gone through the jugular root. So we had to rethink about the entire strategy. And the table moved on the other side of the patient, on the head end of the patient, and we had to strategize the new part, how to do it. But on the spot we decided to do this through the jugular root because patient had interrupted IVC, draining into the left hemizygos, draining into the left persistent SVC. So he didn't have the access from the femoral. Hence we did this through the jugular route, and this is also possible. The only thing is that this jugular route is very consistent with the entrance to coronary sinus, so you have to be very careful that you are actually going into the right ventricle and not going into the coronary sinus. So these are some things to be remembered, but this is the latest achievement that we have done in leadless pacemakers. Now, what is next? Next is a dual chamber, actual dual chamber, 2 micras, two leadless pacemakers in the heart. That means one in the atria, one in the ventricle. This is coming from another company. This micra is from Medtronic. This is coming from another company called Abbott, and they actually have done the first human implant in February 2022, that means 1 year back in Prague. And there are 2 micras, one in the upper chamber, one in the lower chamber, and the Bluetooth technology which you use in your phone, actually these 2 leadless pacemakers are using to communicate with each other. It will pace the atria also, sense the atria, pace the ventricle, sense the ventricle. So this is the future. It will be available in India in 2023 by the end of, I think, September. It will be available in our country also. Now, this is one part of the pacemaker technology that I talked about. This is the other, the conduction system pacing. This is changing actually the way we do the conventional pacing. So coming back to the conventional pacing, this is the normal paced ECG that we see in patients. The wide QRS that you see is because of the RV apical pacing. This results from the conventional pacing that we do. And we have numerous studies, all those people who do echo, you have seen that the strain pattern has shown that it leads on to RV dysynchrony. The RV contracts before the LV, and it is a dysynchronous RV that you have, which has caused not only LV dysfunction in the future, atrial fibrillation, and sometimes sudden cardiac arrest also in these patients because of LV dysfunction. Now what happens actually, this cartoon shows, this is how the wave of depolarization goes. From the apex to the base. This is totally reversed from the normal physiology. Normally the physiology is that this bundle is here, this bundle is here. From the base to apex it has to go, it is totally reversed. We tried doing various sites, we tried doing in the right ventricle, we went to the right ventricle outflow tract, apex, high septum, low septum, nothing worked, everything was dysynchronous. And then we came ahead and told you all that the conventional physiological pacing is actually biventricular pacing, that is the CRT. Even I, one of my CMEs have told you this, that it is the synchronous pacing that we are doing. But look at this, you have one lead in the LV that is on the epicardial surface. So the wave of depolarization goes from epicardial to endocardial, which is totally reversed. In your hearts, it is actually going from endocardial to epicardial. So this is a conventional form of pacing, but it is not the ideal physiological pacing. Henceforth came the His bundle pacing. We started putting the lead from the RV apex to actually the His bundle. We went ahead and did it at the His bundle, and it is my proud privilege to share with you that all the physiological pacing work has been done by Indians in United States of America. All are Indians. The first case was done by Dr. Deshmukh. This was the first atrial fibrillation with complete heart block patient. He went ahead and stood the lead at the His bundle. This was a new lead which came in. It was a humanless lead. It was a beautiful lead and gave wonderful results, resulting into a narrow QRS. I will show you one example of the case that we have done. Sorry. This is, the cartoon is showing, sorry, just a second. Yeah. So this is how His bundle pacing depolarization wave goes. It goes actually in the most physiological way possible, as God Almighty has given to all of us, because it passes through the conduction system and depolarizes the heart. So this is the physiological pacing. I'll give you an example of this patient, 75-year-old patient who had hypertension, OSA. He had paroxysmal AFib. He underwent a dual chamber pacemaker for 6 sinus syndrome. And when his device was checked about a couple of months later, his RV pacing had become actually almost 90%, and he had atrial fibrillation. This was the graph. At the starting, his LV function was normal. There was almost zero burden of atrial fibrillation, and RV pacing was also less, but it kept on increasing the ejection fraction went down by the end of 1 year and atrial fibrillation incidence went so high. Now, this was his paced ECG. Can you see the white QRS here? Right? And if you see the baseline ECG, it was narrow with the first degree AV block and 6 sinus syndrome, he had pauses there. So this is the narrow ECG, and this is what resulted from the RV apical pacing. That is what was giving him dysynchrony. That is why he was having atrial fibrillation again and again. So what did we do? We just removed the RV lead from the apex and we implanted at the his bundle. This lead, again same dual chamber pacemaker, just the position of the lead. We removed the RV lead from the apex and positioned it at the his bundle. And look at his QRS. This is his resulting QRS. And when I overlapped it with the actual QRS, that baseline QRS he had, it is absolutely same. I've just done the overlapping of the two ECGs. It's a narrow QRS. It's a beautiful narrow QRS which has resulted from the his bundle pacing. And what happened to him? So this was here, somebody had done an AFib ablation also for atrial fibrillation. It didn't work. Still it started, the ejection fraction didn't improve. Then we revised the lead and look at this. Within a couple of months, within 4 months, his ejection fraction came back to normal. No atrial fibrillation, and he was pacing, of course, his bundle pacing, he was pacing 100%. And this is how he improved. So these are beautiful ECGs. You know, you look at these wide QRS ECGs with ejection fraction of 20%, left bundle branch block. Initially we were doing CRT in these patients. Now we can do dual chamber his bundle pacing and reduce the QRS to narrow and improve the ejection fraction. The EF improves beautifully here in these patients. If you see, this is how the cardiac size goes down and ejection fraction improves. And for the information of everybody, there are no randomized controlled trials available for this therapy. Despite that, they have made it into the guidelines, the ACC AHA HRS guidelines as a class 2A indication, which is very, very promising. That means they must have seen something in this therapy to make it into the guidelines for patients who have LV ejection fraction which is less than 35%, less than 50%. In case the RV pacing is supposed to be more than 40%, these patients can either be given a CRT or can be given a his bundle pacing. Now we have moved on to doing patients for left bundle pacing. The left bundle pacing, the his bundle pacing area is only 2 mm, but left bundle area is large and it also results into the same. We have seen that his bundle pacing and left bundle pacing gives us the exactly same outcome, which is a good. Also started doing left bundle pacing. This is a very interesting case. This is a 52-year-old female who came to us from outside this country. She had LV dysfunction, 20% EF, and she had CKD. She was due for a renal transplant. And somebody outside India had put a single chamber ICD, that also from the right side, because she had the shunt on the left side for dialysis. Now, once you give the ICD from the right side, first it is not beneficial. Second, he didn't look at the QRS, which was wide. The patient had a left bundle branch block. So she should have been given the advantage of getting either a conduction system pacing or a CS pacing, to improve the heart function, which will improve her outcome for CKD once she undergoes a renal transplant. But they just did a single chamber ICD, and I convinced her to undergo a conventional CRTD by a conduction system pacing. But once I took the shot of the right subclavian, look at this. There is all stenosis with all collaterals here. So there is narrowing of this vein because of the previous lead. But I could see a flow there. Hence I cannulated this. I took the puncture and we passed the wire. It was a task. It required a lot of experience and a lot of playing with the hardware to take the access, but we were able to do it with the Teramo wires, and then we did the left bundle pacing. This is how the left bundle pacing is done. You can see I've given a shot, I've taken a dye shot from the catheter, and we can see the septum. So it has gone to the left side of the septum. This part is on the right side of the septum. This part is on the left side of the septum. There is a left bundle potential on my lead. Here it is seen very nicely. and it resulted into a narrow QRS, and I was able to put in two more leads in addition to this defibrillation lead to give a better outcome to the patient. This was a narrow QRS ECG with the left bundle pacing which the patient has. Hopefully the ejection fraction will improve. And this is our happy team. After doing a lot of work, it took about 3 hours to do this case, and we were all very happy and excited. Now, you know, my only example which I can give about the conduction system pacing and the conventional pacing is, conventional is good. We all love Aishwarya Rai. Even when she was looking like this, you know, but we all like her like this better, right? So wider is not good, but narrower is of course the ideal situation. And that is what goes with my pacing therapy also. So I think you all should concentrate on that. Whenever you are referring patients for pacing, please send for conduction system pacing. It will benefit your patients, and you will be happy seeing the ECG also, like you are happy seeing Aishwarya Rai. Okay, now this is a video which I am putting in. It's a social cause with a request for Dr. Chauhan. Yeah.
They are asking for narrow and short, crisp.
We have some questions.
नहीं सर ये बताइए.
ये तो बता दो.
ये मैंने डॉक्टर चौहान की रिक्वेस्ट पे डाला है. सर ने बहुत इंपॉर्टेंट पॉइंट किया था. I'm going to show you this video. This has gone viral on the net.
Yeah.
Please see this video and you tell me what has gone wrong here. I will ask you the question first. Then you can ask as many questions as you want. What went wrong, sir?
Cardiac arrest.
Yes, sir. Cardiac arrest was right, but what went wrong? Please see the video.
Arrhythmia.
Yeah, please see the video.
VF.
Ventricular tachycardia, ventricular fibrillation.
Yes, sir. What went wrong? Again.
V flutter.
See this.
Probably has a family history, you know.
See this. See this.
There is no QT interval or
This is what went wrong, sir.
This is what went.
It was not arrhythmia which went wrong. Arrhythmia had to occur because he was prone to it.
She was not given the recently
CPR was not given and he was being taken like this. This is what killed him, not the arrhythmia.
No,
so my message to you all is...
No, Dr. Vanita, what was the precipitation cause?
That is different.
Sir, that is different. What went wrong here? What will you do? Just say that.
What will you do in the CPR?
Please propagate this. You are seeing so many videos going viral every day. ये मर गया, इसने क्या हुआ, इसको क्या हो गया, वहाँ हो गया, सब कुछ हुआ. Agreed. You cannot control arrhythmias, but you can learn, you can teach how to manage them. Please learn CPR. Please teach CPR to each and every person you get hold of. Whether it is your servant, whether it is your any police officer, any railway officer, schools में, please आप सब लोग join करें हमारे को, इस मुहिम में join करें. We have to teach CPR and we have to make the importance of AEDs, automatic external defibrillators, available wherever there is a fire extinguisher. There should be an AED everywhere.
So was he asystole or was he in fibrillation at this point of time?
Whatever it was, CPR had to be started.
Yeah, your point is well taken.
They are picking him up. He is in hypotension. That's why he fainted. They were not supposed to pick him up. They were supposed to start the CPR immediately. He was lying flat on the badminton floor. Right, badminton court के floor पे बैठे हैं, सीधे हैं. That is the first thing you have to do for CPR. That make the patient to lie down flat on a stiff floor so that you can do a good CPR. But they are picking him up.
Yeah.
That is the most foolish thing.
We'll talk about this case later on.
Your point is taken.
Yeah.
Even singer KK died because of his height.
Absolutely.
He was not given.
He was not given anything, sir. He was taken. You see the video. He was taken. उसको drag करके लेके जा रहे हैं. होटल ले गए. अरे hospital लेके जाओ. He was sweating so bad.
We saw a video on WhatsApp that a bird was doing CPR to another bird. So to the extent that we should learn from that.
Yes, sir. Absolutely. Now, please, your question.
Next.
Thank you.
Ma'am, we'll have the question that is.
कुछ धड़कनों का जिक्र हो, कुछ दिल की बात हो. तब उन दिनों में नया मेडिकल स्टूडेंट में गया था. I was student only. तब तक पेसमेकर इतने ज़्यादा पॉपुलर नहीं थे. तो अब मैं सोचता हूँ कि शायद ये पेसमेकर की बात कर रहे थे. Dr. Vanita, for you. So I saw a very vast serial on Netflix, Blacklist. कोई ना देखना, बहुत लंबा है. 150 घंटे खराब हो जाएंगे। उसमें एक इमेजिनेशन ये भी था कि कोई किसी के पेसमेकर को हैक कर लेता है। तो आई एम जस्ट आस्किंग, इज इट पॉसिबल?
I've seen Blacklist, sir. It's one of the best series in Netflix.
Everybody must see.
Anybody who has a detective mind and likes the criminal stories, you should go and see that.
And also the innovations.
Yes, absolutely.
Every innovation, including gene therapy, gene changing, and everything.
Everything.
Yeah, please.
So how to escape from murder also they teach you there.
Yeah.
So Dr. Kalra, would you like the audience to ask questions before you ask?
Yes, sir. I am setting the ball rolling. I am igniting the fire. Sir, मैं ये पूछना चाहता हूँ कि ये जो leadless pacing devices, what do you do if a person dies? Because for other devices of pacing, we are supposed to take them off because they will burst. What for leadless? Because they are so deeply implanted. Please.
So you asked me two questions, sir. I'll answer the first question of Netflix first.
Yeah.
What happened in that series was that a very important personal politician had a pacemaker in. And what they did was they hacked the therapy and stopped this pacemaker. So this used to be possible because they have some of the pacemakers have been introduced, devices also have been introduced with the Bluetooth therapy. Now initially they also had the problem, so they had to discontinue this therapy because it was hackable. Now they have closed the circuit. The circuit has been closed. Due to the technology is still available, we have remote monitoring also available. But remote monitoring which is available in India, it is not programmable. We can see the parameters but we cannot program or reprogram them. So this was possible. Now they have closed the circuit, they have went ahead and rectified the problem. Now the answer to your second question, that is what do we do in case a patient of leadless pacemaker dies? See, the pacemaker which was outside, when it was outside the heart, that used to burst during cremation because we burn the bodies, right? So it used to burst. That's why we used to tell the people that, let us remove the pacemaker or the device before the cremation is done, because it used to be a shock to the family doing that. With the leadless pacemaker, it is inside the heart. And it is such a small pacemaker, 0.8 cc volume, 2 gram weight, that there is no resultant blast is not there. So we just leave it there.
In the series of half questions I am asking, charging from outside or without a charge, are we in the pipeline hoping some pacemakers coming without a battery or a battery chargeable? We are coming with mobiles without charging leads. They will be charged from some slab, they will put on slab and they will be charged. So what is the pipeline?
Sir, we don't have any information on charging from outside, but we do have information on biological pacemakers. Probably your next generation of patients which will come after 10 years, instead of leadless pacemaker, we will be giving biological pacemakers. So they are stem cells related and some related to some things that we will be introducing in the heart to stimulate the conduction system.
That was my last question, which you have already answered, but I think there will be charging from outside also possible.
That's very good, sir. That will be good news.
Great talk, ma'am, on the advancements. I just wanted to ask you regarding the Micra that you showed. Ma'am, it costs huge amount of money. I had got it put in one of my patients in Max by Dr. Viveka, and it cost me Micra AV, ma'am. It cost him 15 lakh rupees.
Sir, you should have sent him to me. I would have done it in 12.5 lakhs.
Okay. No. I mean, let's let 12.5, 15. Who pays 15? I mean, who will pay 12.5 doesn't mind paying 15.
Correct.
It's only a question of perception where he pays. Ma'am, what I want to ask you is, now you also mentioned about the his bundle pacing. That which looks to be the natural pacing.
That's correct. That's correct.
So, what about choosing patients for his bundle pacing rather than Micra AV, ma'am? Your comment on that?
So it was a very nice question, very interesting question, and this is, what we have to see is that the indication of the patient should be correct. I do not say with this cost, leadless pacemaker is for all the patients. It is not. But in case the patient has infection, the patient's site is blocked, it is an alternative route. patient has bad COPD, you don't want to put in a needle to take an axillary or a subclavian puncture. In those patients, it acts ideal. But in other patients, which will be, I would say, 90% of our patients, right? The way forward is conduction system pacing. Not the traditional pacing which we have been doing in the RA and the RV mitral pacing, but his bundle or left bundle pacing. But Micra leadless pacemaker, so there is another company which is coming with it. As of now, Medtronic has a, they have a, they are the only ones dealing with it. That's why they are not coming down on the price. Now Abbott is coming out with the pacemakers. It's already started in Europe and in the US. The implants have already started. So once the competition comes in, the prices will go down. But I don't still say that it will go down as the conventional pacemakers. It will never come to that. So we have to select our patients well.
Ma'am, how much does this bundle pacing cost in your setup?
Okay, so his bundle pacing, so suppose a dual chamber pacemaker in our institute, Apollo Institute, costs MRI compatible, dual chamber, rate responsive, with lifetime warranty, costs 165. And if I do a his bundle pacing, it costs 210.
Ma'am, another question is, which is for everyone. We have some very bad patients who have had multiple infarcts and who have severe myocardial fibrosis. And you showed some of the ECGs, You showed Aishwarya Rai of 30 years ago when she was Miss World. Very sleek QRS complexes. And you showed Aishwarya Rai after her first delivery. A lot of weight gain. And they are very, very broad QRS complexes. One really fears, as an electrophysiologist, you would be fearing that you would like to see them.
Absolutely.
When there is severe myocardial fibrosis, in that kind of scenario, what would be an ideal pacemaker with complete heart block?
Sure, sir. So if there is a lot of myocardial fibrosis, there will be LV dysfunction, right? So you cannot give just a pacemaker in that patient. You have to give you have to put a lead in the coronary sinus, and you have to put a lead at the his bundle or left bundle. So this is something known as LOT CRT. That means left bundle pacing with CRT, or hot CRT. That is his bundle pacing with CRT. We have to combine it because when there is fibrosis, the disease actually in the conduction system is very distal. So only coronary sinus pacing or only his bundle pacing will not work. You have to give a combination of these two and then benefit the patient. I have done that, sir, in a lot of patients, especially in patients who had single chamber ICD and who did not have a left bundle branch block but had IVCD or right bundles. Initially we used to just give them ICD and leave them alone. In those patients, once they come for replacement, I have upgraded them to either LOT CRT or hot CRT, and their ejection fraction has improved very nicely.
Ma'am, one of the commonest arrhythmias in practice is not the complete heart block, it is atrial fibrillation.
Yes, sir.
As a physician. And now there is a lot of technological advancement on atrial fibrillation, including 3D mapping. And we know that the areas of trigger are around the pulmonary wall, pulmonary veins.
Yes, sir.
So I would have liked to see some of those slides from you, talking on technological advancements. Your view on atrial fibrillation, 3D mapping and ablation.
Sir, very interestingly, patients of sick sinus syndrome actually have atrial cardiomyopathy. There is a lot of fibrosis in the atria. Even if the atrial size has not gone up, there occurs a lot of fibrosis. And that we realize once we enter the left atrium with the ablation catheter to map the entire atria, we see very low voltage areas. And then that is the time we realize that these patients actually have a very low voltage ground. So isolating only pulmonary veins gives us a good result in paroxysmal AFib. The first procedure result worldwide, success result in paroxysmal AFib with pulmonary vein isolation is about 80 to 85%. Whether you use RFA or you use cryo, it's equal. No study has shown that cryo is better. Cryo is cooling therapy, RFA is burning therapy. Now, apart from that, if your patient doesn't have paroxysmal AFib, patient has persistent AFib or a chronic AFib. Chronic AFib, it is a no-no. There is no role of ablation in chronic AFib like patients you have of rheumatic heart disease. Because the entire atria is fibrosed and dilated. So atrial diameter more than 5 centimeter. If you are doing an AFib ablation, you are actually not only fooling the patient, but you are fooling yourself.
That is 5 centimeters or 4.5 centimeters?
It's a 5. 4.5 also I have seen. If it is persistent AFib, you are able to isolate the veins, you are able to get the patient into the sinus rhythm, it stays. So that vicious cycle, if you break of AFib, the patient stays in sinus rhythm very good. And the atria remodels. It remodels itself, it comes to the smaller size, and the patient does better.
Now, one of the greatest issues in arrhythmias is not the arrhythmia itself, but the consequences of arrhythmia. And one of those consequences is a clot, which then embolizes. So, what about LA appendage closure?
Yeah. Sir, LA appendage, in case patient is unable to tolerate the NOACs, non-valvular AFib, NOACs cannot be given, or they have a bleed with NOACs or with the acetron and with the anticoagulants that we give, acetron or warfarin. Then, sir, if they had a bleed, that means we will not be able to anticoagulate them again at the level that we want. We will have to use lower doses and keep the INR low. In those patients, plugging the left atrial appendage device with the left appendage atrial device closure is a very good therapy.
The cost in your setup, ma'am?
It will be around 3 lakhs.
All right, ma'am. And Dr. Podar has a question.
Yes, sir.
Yeah, Dr. Vanita, through femoral route, you first reach right atrium. So, how do you reach right ventricle? Through valve or you puncture the ventricular wall?
For leadless pacemaker?
Yes.
We don't puncture the valve, sir. We cross the tricuspid valve.
Through valve, yeah.
Yes, through the valve, we take a deflectable tool, we go into the right ventricle and we go towards the septum. So we don't go towards the apex like we conventionally do. We stay towards the septum side. Initially we used to go to the apical septum. Now we have started doing in the higher septum and mid septum.
Septal wall, you
yes, sir.
Fix it in septal wall.
There are trabeculae there. We look for the trabeculae and once we find the good trabeculae, we just fix it there.
And then you talking about leadless pacemakers, when you need a defibrillator, then any other choice?
We can do subacute ICDs, sir.
That's the only choice.
The subacute ICDs we can do. In case you want to be totally leadless, we can do a subacute ICD and a leadless pacemaker combined.
Okay, thank you.
Welcome, sir.
Ma'am, I just wanted to know, do you have a helpline where, suppose I get a patient with arrhythmia in my clinic and I can reach out to you? Because do you have a helpline which we can call? Somebody will attend it 24/7.
Yes, sir.
Is it possible?
Yes, sir.
What is that helpline?
987387994.
Is that your number?
Yes, sir. That's my official number.
Okay. And you are available, ma'am, 24/7?
That's my official number.
It should be broadcasted.
Sure, sir. I'll do that.
Is it available 24/7, ma'am?
Yes, sir.
All right, ma'am. Ma'am, one question, ma'am, which my friends have been asking, prompting me to ask. Ma'am, with all the technological advancements, with beautiful pacemakers and, you know, micra lady and slim looking Aishwarya Rai, ma'am, is there any mortality benefit?
With leadless pacemakers?
Yes, ma'am.
Sir, there is no data as of now which is showing that mortality benefit is there. But morbidity benefit, yes.
Alright.
The reimplants, the fractures of the lead, the infection rate and the hematomas which used to lead to reopening of the pouch and pocket and then cleaning again. Morbidity has improved. Mortality, we don't have that long-term data as of now.
So, ma'am, the carry-home message that you gave to me as a physician was that if you put the leadless makers about the whatever number you said, I think 90,000 if I remember.
So worldwide 70,000, more than 70,000 have been done. In India about 500 have been done.
Not a single infection.
Not a single infection.
Great. I would like Dr. M L Kalra sir to summarize this part of the CME before we move to the next one.
Can I just say one thing? Can I just say one thing?
Yeah, please.
What is infection? You know,
Sir, you are asking the next question.
No.
Sir, you are asking the next question.
Vanita,
Okay, I just wanted to ask, because you touched this point of infection, I've been thinking about this. And it's a bit hard to digest that in 700,000, no,
70,000, sir.
70,000. Because this acts as a lighter.
No, sir.
It doesn't act as a
No,
lighter.
it doesn't.
Sir, I have
That is
one
the beauty
question.
of this.
Why is that?
So the substance that they have used is inert. So the infection doesn't get subsided. In active infection, we have put in micra. Active infection means the patient's pocket is bad. We've removed the pocket site device. We have removed the leads. At the same time, we've implanted
No,
micra.
infection may not be early, it can be late. Like
Sir,
for
even
our
late infection,
implants, we
2016
do
to
get
now.
late infection also.
2016 to
Sir, we
now.
would discuss it over dinner. I would request Dr. Anand sir to
Control the question.
Pacemaker.
Yeah.
What about the battery's life?
Sir, 100% pacing 10 years.
Then when the patient is again, that is again this.
So we will remove that. We have a snare which holds that device. It removes it and we implant a new one.
Anyone has a question? Anyone else has a question? Please, go ahead, sir. Ask him.
हाँ सर पूछिए पूछिए.
So that was a very fascinating talk by you, and can we say that probably the heart rhythm last year had some momentous moments, see, to say that the recent advances in cardiology has gained a new height. I am talking about the Atlas S sudden cardiac death trial with the subcutaneous implantable cardioverter defibrillator. So probably you see risk of lead-related complications by a relative 92% as compared to transvenous system without a significant difference in the device performance. What do you say, ma'am?
Sir, about the subacute ICD, the data is still limited, and yes, it is very promising because it is put in a specific category of patients. It is not meant for all patients who have LV dysfunction, who have ischemic cardiomyopathy. It is given in patients who are young, who have hereditary cardiomyopathy, which means they have either long QT, ARBT, Brugadas. And it does not have a backup of pacing, which we require when we defibrillate the patient. So they have done a couple of cases of subacute ICD with micra. With Bluetooth connections they have done, and they have done, micra has given the backup pacing. But if you talk of data, whether subacute ICD is going to replace the conventional therapy, as of now, no, not yet. It is meant only for very specific number of patients.
So, ma'am, probably the future lies in here. The leadless pacemaker, which is a dual chamber pacemaker, recently introduced by Abbott as well. So, reduce mortality, reduce heart failure hospitalization as well. Just a word on the recent, just recently approved, the Abbott system.
So Abbott system actually has two devices. One we set it in the atria, the other will go into the right ventricle. The technology.
So, right atrium and right ventricle, friends. Yeah.
Right, sir. And it will pace and sense the atria, it will pace and sense the ventricle. As of now, micra AV only senses the atria, it doesn't pace the atria. So those two devices in two separate chambers will pace both the chambers.
Ma'am, I'm super excited, John, about the bionic pacemakers. Might be, best kept secret as of now. So heart pacing with real-time modulation, design the heartbeat with the patient's breathing. The bionic pacemaker, man. Just a word on the bionic pacemakers. See, this seems to be the future of pacing.
Absolutely.
Tell us a little about the bionic, which is undergoing trials in New Zealand, and probably this trial will be out in the first quarter of next year. Sorry, this year. Go ahead, ma'am. The bionic pacemaker.
So they use accelerometer, that is what is used for actually recording the rhythm and pacing. These are the biological experiments.
I think we will we will request Dr. Tulsi sir.
Just let me give the last line on this.
Last line on this by Dr. M L Kalra sir.
Let me hand over the mic to Dr. Tulsi, which she has unauthorized. Well,
No, yes. Dr. Tulsi does everything only under emergency use of method.
Friends,
Sir, use the right word, sir.
unauthorized को होता है और
Emergency use of method.
धक्का मुक्की करके पैसे ले लिया था। चलो मैं ये कहना चाहता हूँ, मैंने इसलिए ले लिया था कि मैं भी इनके कैंडिडेट्स में भी सवाल पूछूंगा। Anyway, my friends, I just want to say you had a very elaborate talk on pacemakers, and when it was talked about what can be benefit, and we were saying we are pulling a blank. I think it has to be a very good number. When reducing HbA1c by 1%, you get a mortality benefit or cardiac benefit by 14%. So when you are giving a pacemaker to a person, if he had no pacemaker versus pacemaker, it has to be a very good mortality benefit. We don't know the number, but don't take it that there is no